Okay, we are live. I'd like to welcome everybody to Facebook Live. And I can see that we are absolutely live. And it's a pleasure today. We have a special guest, Ron Korn, who's the founder and head of Imaging Endpoints. And he's going to share with us some of the work that he's been doing and some of the challenges we all face in imaging. Ron, great to have you here.
It's a real pleasure. Thank you, Elliot, for inviting me.
So why don't we get started with, just tell me a little bit about Imaging Endpoints. We have a lot of users from around the world who may not have heard of you. So what exactly you guys do?
Great, thanks. So Imaging Endpoints is an imaging research and core lab that began about 12, 13 years ago here in Scottsdale, Arizona. And what we do is we provide our expertise, our experience, and our services to the clinical trial industry to evaluate scans that are part of clinical trials, mainly oncology, but other diseases as well. So we've grown over the last decade or so. We have over 8 offices globally, over 150 people working for us, and really one of the largest and fastest growing imaging core labs in the oncology space. And so today's discussion is very timely since we take care of a lot of sponsors who have clinical trials that have to deal with pseudoprogression.
Right. So I know you do, one of the things as radiologists and technologists, everyone is familiar with doing cancer patients. That's so much of our work is cancer patients and staging and follow-up. But I think one of the big things is, particularly when you're doing trials, but even on day-to-day work, you need to be very accurate. Simply saying the patient looks better or looks worse really doesn't cut it in the oncology world. So what are the core things you do? What are some of the things you do? And what can you sort of teach our audience about what they need to do?
Yeah, it's really, it sounds trivial, but looking at images and evaluating it, even if you have an expertise in cancer imaging or other kinds of imaging, is not trivial. What is really important is that when you're asked to evaluate images, you have to have a methodology of evaluating how patients are responding or not responding to their therapy. And so a lot of what we do is measurements on standard of care images or images like CT, MRI, and PET that really help to measure and judge whether somebody is benefiting from the therapy or not, and in a clinical trial setting. So that means we have to remain blinded to the treatment, we have to remove as much bias as possible, and we have to be as accurate and as knowledgeable about all the different response criteria to do that job effectively.
Okay, and so one of the challenges I think that we're going to really focus on today is really the fact that with some of the really exciting new chemotherapies and immunotherapies, we used to have things very simple. It was 3 centimeters, now it's 2.5. It was 3, now it's 3.5. And it was obvious, that's all you had to do. It was really simple. Why don't you tell us now what some of the problems are?
Yeah, so you hit the nail on the head. In the old days, when you had chemotherapy that just affected both normal cells and tumor cells, you were really looking for tumor shrinkage. And it was very important for us to define a methodology in which you can accurately gauge tumor burden and then ultimately tumor shrinkage or growth. And that's where the RECIST criteria started to develop, where, like you said, you looked at your patients at baseline, you determined, you looked at all the lesions, you determined which lesions would best serve as target lesions so that you can measure their actual size using a ruler. Then you looked at the other lesions that weren't part of the target lesion category to follow them on subsequent imaging studies. And then you're always looking for new lesions. And so what the RECIST criteria, as most of us know, had worked pretty well and continues to work fairly well in common chemotherapy type of trials. In fact, it's really the only response criteria that the FDA considers quote unquote validated for use in clinical trials. But with the development of the revolution in immunotherapy, things have changed. No longer do tumors simply shrink or grow, but they have all kinds of different, what we call atypical responses or properties, in which they begin to grow and subsequently they begin to shrink. And we call that pseudoprogression, I think, as most of our listeners are aware of. But there's also a whole host of different processes that we see on imaging, such as hyperprogression, where tumors not only grow, but they go really fast. And these disassociated responses and things like durable stability. So no longer is it enough to put a ruler down and measure a lesion, but you really have to have a comprehensive approach to evaluating what's going on with the overall tumor burden, both at an individual time point, but also over time. And that's where all these other response criteria that I think your listeners are familiar with, the immune response criteria, have really come into play in order to try to capture these different types of atypical response for more accurate ways of measuring tumor treatment efficacy.
So how tricky is it? I mean, because obviously, it was really simple with the classic chemotherapy, bigger or smaller. It was just a matter, was it 10%, 20%? But I know now, myself, we all struggle because when you first start looking, first of all, you have to learn about the different chemotherapies, right? And immune therapy. So right away, it's that changes things. So you need to be very aware of what the patients are getting and the fact that this can be one of the issues.
Yep.
That's one. But then the second thing is when you're looking at time points, what do you, again, how do you know that you're doing it correctly?
Yeah. Yeah. So the most important aspect, especially when you're doing a blinded independent central read, unlike what you might have in your own practice, is you're really only given the current time point and all the prior time points. You're not really allowed to look in the future to see what happens. So you're really doing real-time evaluation. And there, what you first have to do is you have to recognize that pseudoprogression does exist. So that's very important. Secondly, you have to be able to understand the basis of these response criteria, which all have as their skeleton, if you will, resist. So you got to really understand which target lesions to look for, what to consider non-target lesions. And then you have to be prepared to see either new lesions appear or new lesions growing and accurately capture that new group of changes in your scans. And right now in standard imaging processes, it's really hard to know whether you're dealing with a true progression, a pseudoprogression, or hyperprogression when you're looking at things real time. But there are certain things that you can use that might help you in that regards. And some of them we can certainly talk about in more detail, but ultimately it's a test of time that really determines whether or not you're dealing with one of these three types of progression.
So when you say test of time, how much time do you typically need, from, let's say, start of chemotherapy? At what point do you really feel comfortable that you're seeing the response or you're seeing pseudoprogression? What does it take?
Yeah, pseudoprogression most often occurs very early on after the start of therapy, especially immunotherapy, usually within the first or second cycle. So the first month or so of treatment. Sometimes within the first couple of weeks, clinicians, for example, melanoma, can see skin lesions start to grow and more appear. But you really are trying to look at pseudoprogression as early as possible, which is around 8 weeks from the start of therapy. Once you've identified it, it's really important to follow up in a reasonable time period because the clock is working against the patient. If you're dealing with true progression, you got to get them off the treatment as fast as possible and onto a new therapy while they still have a really good performance status. And so in that regards, you usually wait between 4 and 8 weeks to do a repeat scan, no sooner than 4 weeks, but no later than 8 weeks in solid tumors to look for whether you're dealing with pseudoprogression or not.
Okay, and then so is there a typical appearance when you're looking at images? You're looking at typically contrast enhanced scans. You train a lot of people. I mean, obviously, one of the things that you guys do is train many readers. So it's not like, because it's one of the things, I don't think there's that much literature about it, right? There's a little bit of literature. I think a lot of it's focused on the problem with false positive, people reading recurrence when there's no recurrence, and then all of a sudden people coming off therapy for no reason. How do you train people? What do you teach them to look for in terms of that?
Yeah, so you really train them to look carefully at where all areas of disease occurs when they're looking at the screening or baseline scan. So they really have to have a good sense of what that patient's overall tumor burden is. And that really involves looking at good CTs of the chest and pelvis or MRI and other areas where there's known or suspected disease. Then on the first time point, you really first have to make them aware of that in your clinical trial, you might actually have a type of drug or treatment that does create pseudoprogression. So that when new lesions come up, that they recognize it, they can identify them and measure them correctly and follow them, know what the new tumor burden looks like, so that when there are changes on subsequent films, they're very confident in whether or not they were dealing with the pseudoprogression or not. Unfortunately, just by humans looking at these new lesions, there's nothing that tells us that, gosh, this lesion that just showed up is, a new lesion that's related to pseudoprogression or a new lesion that's due to true progression. For that, we're using advanced technologies and techniques such as radiomics to help us try to see if we can figure that out. If there's anything inherent in the signal itself within the lesions that can distinguish true progression from pseudoprogression. And I think the difficulty, of course, is what drives tumors to grow or new tumors to appear. And there are two biologic mechanisms of pseudoprogression. One is that it takes time for the immune system to kick in after you begin treatment. So tumors just naturally grow and new ones appear. And then there are those tumors which actually appear to grow because of swelling due to the infiltration of the immune system. The former, it's very difficult to use imaging to figure out whether that growth in tumors because the immune system has yet to activate it or whether or not it's true biology of the tumor. The latter one, where you're looking for whether immune infiltrating cells are happening, that's there I think imaging can really begin to address that type of pseudoprogression.
Okay, and one of the things you mentioned is sort of near and dear to our hearts. We've been doing a lot of work for a few years now with radiomics and pancreatic cancer. I think one of the things that somewhere between AI and radiomics, what's your thought about these new technologies? As I think we've gone a long way. We've gone 40 years, 50 years of CT, or we've done a long time with measuring things. Now we have these new issues because of new medication, new drugs. Things like radiomics, you think that's going to be a major impact, or even AI in general in this process?
Oh, I think it absolutely will, because it really leverages data that already exists on the images that it's hard for us to put a ruler on. And so things like radiomics, where you measure the texture or the interaction of the tumor with the surrounding host, is really, I think, going to be supplementary and beneficial. And I think that will really ultimately help us in many of these difficult cases. Radiomics, as you know, is still in its infancy. We were the first core lab actually to apply it in clinical trials. And so we're very bullish on it. But you got to be careful, because what people sometimes measure is not the true changes that occur in lesions, but the true differences between the technologies or the technical artifacts between scanners. So there is a future. I think AI will help solve it and integrate these large data sets. But we need better ways of standardizing how radiomics is done, what the definitions are, and what are we going to look for that tells us the difference between true progression, for example, and pseudoprogression.
Yeah, no, I think the radiomics, I know, like we did with pancreatic cancer, you looked at 497 features, okay? Maybe 10 of them were very important at the end of the day, but and the thing bothers me about radiomics, we've been successful, but everyone's successful. You never read a bad article that says radiomics.
That's right.
Now, that always bothers me when everybody is successful, whether they're looking at recurrent tumor versus non-recurrence, separating pancreatic cancer from normal pancreas. The fact that it works for everything, nothing works for everything, and no two people seem to be doing it the same way. At least if you did it all the same way and everyone got really good results. So I think the point you make is really true, is radiomics is still I won't say it's a black box, but it's kind of a black box because there is no rules or reason in it.
Yep. I agree with that. And there I applaud our different radiology societies like KIBA and others that are really trying to standardize the process of radiomics. I think once that gets settled, then advancement radiomics will really make an impact on what we do.
Yeah, hopefully it'll be, I mean, a number of the, I know like things like NVIDIA is looking at trying to create some standards. I wonder if it's going to take, an NVIDIA or a Microsoft or Google, someone,
Yes.
which really has the high computer to kind of put everyone, I don't think anyone's really worried about, I mean, I don't think anyone worries if someone else coming up with a standard, as long as everybody is in the same ballpark of doing it. So what else in terms of, the way you guys work, looking at these difficult problems? And I'm
Yeah.
sure, these things constantly come up. And obviously, a lot of the work you do relates to companies with new drugs who then need to go to the FDA, who really want science. I mean, FDA really wants proof. It's not that I think it works.
Yeah.
How do you deal with things like that? Particularly when you're a cutting edge. It's easy to go back to research. Okay, they approve that. But all this new stuff, how does that work?
Yeah. So what you have to have is you have to have a really good prospective plan going forward. So it really starts with the protocol. You really have to work with sponsors and define exactly what you want to do with these advanced imaging techniques. What are you trying to accomplish? Are you trying to look for a better way of measuring response? Are you looking for a way of making sure that your drugs are altering or changing the tumor microenvironment, et cetera? So you really first have to start with, well, what are your key objectives? And then secondly, as you mentioned, a lot of these advanced techniques like radiomics are really very helpful to sponsors in an exploratory sense. It either gives some indirect or direct evidence of proof of mechanism or not. And occasionally, the FDA will look at that as supplementary information and say, yeah, not only did you meet your endpoints, but look at, you got this other kind of data here that is very valuable, and it's going in the direction of either, a positive outcome or not. And so, the key there is to make sure that your data is robust, that you've done it according to your protocol, that you have considered all the different factors that can affect the results, and that it's in the background of making sure that you really have accurate measurements of outcomes, mainly response rates, PFS, things that radiology is very important in using. And so we really make sure that we've bolstered and that we have the best of both operations going on in a clinical trial. I can tell you just real quickly that FDA is becoming more and more interested in this kind of work and in learning. The one thing about the agency is they really want to know more. They really are a sponge for new information. So it's also an opportunity for education.
So I know we're running out of time, but as you mentioned, education for radiologists in practice or technologists, particularly radiologists in the oncology space, how do they learn about these things? I mean, you could read some articles, but how do you know if you're training someone new to work on one of your projects? Is there something you obviously you do, because you need high quality people, reproducible work, and it's not one person's good and one person isn't.
Yeah.
Everyone needs to be great.
Yeah, no, that's absolutely right. And so we have a very robust process in which we bring readers onto a clinical trial, whether they're very experienced or have a limited experience. The most important thing is that first of all, that they are qualified to read the modalities that we require. Secondly, that they undergo a very robust training process where we sit down, give them examples, go over the criteria. And third, they have to understand what clinical trials are all about, that it's not about personal opinion at that point. That's what clinical radiology is. You think somebody's better or worse, that's what the art of medicine is. And that's of great value. But in a clinical trial, you follow the rules. And so although radiology judgment is still very important and is a consideration, you got to train people to do what they're supposed to do and to come to a consensus of how to make judgment calls when you're in these gray areas. And then once they're in the trial, we monitor their performance. We make sure that people are understanding the rules, that they're following the rules, and that everybody's reads are pretty much in line with what we expect from our metrics that we take. And we have found that the readers that we have at Imaging Endpoints, they always come back and say, you know what, you made me a better clinical reader. Because now when a case comes in from my clinical care from doctor oncologist, and they want me to do resist where I resist, I really know what to do now. So I think there's benefit radiologists to get involved in clinical trial reads.
Right. No, it's true. And also the fact is, at the end of the day, I mean, it's one thing when you're at conference when you discuss a case, but when you have to read it, you have to read it correctly without your opinion. Now you could put in the summary, well, I think maybe it's not, this, that, and the other, but at the end of the day, you have to read it, not how you would like it to be. It needs to be very, very precise. So that's really great. Any last comments you can tell our audience? So I guess they can go to the website, your website, and read a little bit more about what you guys do and about some of the things that you're looking at now, right?
Yeah, absolutely. And please do. And your audience can feel free to reach out to me. We're in an exciting time with radiology. It's really making a huge impact on drug development of all different kinds of diseases, not just only cancer. And there's new evolving technology that really does have to find a home in these clinical trial environments. And so, so I think the readers can really stay informed, try to keep up to date, and participate in clinical trial reads. I think it'll elevate everybody's vote.
That sounds great, and I do appreciate. It's great seeing you, and
Always great seeing you.
I think it's very exciting, and this. So hopefully people understand now about the pseudolesions. You can read about it, because if you're in a cancer center, these drugs are being used routinely now, whether it's melanoma or for some of the other cancers, solid tumors. And if you don't know about it, you're going to be reading the cases incorrectly. I mean, that's the other thing. And the worst thing to do is have the oncologist know better than you know. So I think as a radiologist, we need to kind of know what they're doing and how it affects our job. So,
absolutely agree.
Okay. Ron, thanks a lot. I really
thank you. What a pleasure. It's great to see you.
Okay. See you later.
Thank you. Bye-bye.